already. Okay, so for the first aliquot, it's the chief complaint. So this was a 72-year-old female that was brought to DR by her family with a chief complaint of progressive weakness. She said that she started feeling weak on her both arms and legs for 2 months, and in a month she couldn't walk or hold anything. She couldn't dance, which was an activity that she really enjoyed. So her life changed a lot. That's it for the first part.
Amazing, y'all. Rafa or Shema, can I ask you guys to share the screen if you don't mind? And Sammy, take it away, please.
Yeah, what an interesting chief complaint. Weakness and progressive weakness since 2 months, which I put more in the chronic progressive bucket, or subacute to chronic progressive bucket. And the neurologic exam is going to be really interesting if we have any signs of upper versus lower motor neurons. It's also very important because a lot of chronic conditions can manifest with fatigue or weakness, and it's important to differentiate between asthenia and true weakness. And a quick question you can ask is always, are they weak when they are lying down, or is the weakness only when they activate their muscles when they walk? And that would be a quick, fast differentiation between the two. But yeah, I think we have a chronic, subacute to chronic process that's progressive, and this would be my first thoughts. Robbie, what do you think?
I completely agree with you, my friend. I think the key question is this a neurological issue or actually a systemic issue camouflaged as a neurologic issue by the virtue of the words that the patient is using? Because if she said progressive fatigue instead of weakness, she might have meant the same thing, but used a different word. And that's where the beauty and the intersection of medicine and language comes into play. So I don't really know if this is neurologic or not, but I think the fact that she specifies that it's her arms and legs has me concerned that it is neurologic. Though the things that are adjacent to neurologic disease that aren't are ischemic disease. So if she has an aortic disease, actually has exertional pain in her arms and legs. So this is not an uncommon way for aggressive atherosclerotic peripheral arterial disease to have pain with exertion. So vascular diseases are something to think about, as well as orthopedic diseases. So if she has polyarticular arthritis or arthropathy, that's another way that a pseudo-neurological condition. So I completely agree with you. I think if we were to draw out our schema, the first is this asthenia versus neuro? And teasing them out is hard. And then within neuro, there's actually diseases that mimic neuro diseases around neuro, which is ischemic disease to the limb and orthopedic disease to the limb. And you're right. In this patient, you're probably simultaneously examining her and talking to her. Already, Eduardo, Mike, back to you.
Okay, so just a quick disclaimer. This patient, when she was brought to DR, she was actually under the care of the neurology team. But as they evaluated her, they noticed that something was off. So that's when they called the internal medicine team. And I was actually on call with my other fellow residents to evaluate her. So this is what we found out. So she was accompanied by her son, and he says that it all began 3 months ago when she had a sudden hearing loss, ear pain, and fever. So she went to the doctor and they saw that she had bilateral ear effusion, and she was investigated for an ear infection. She was then started on antibiotics, and she was repeatedly treated with antibiotics, but she didn't really improve. A few weeks later, that's when she started developing weakness. It started on her left arm, then progressed to her left leg, and later to her right arm and leg. It was worse distally, but it wasn't like the pattern wasn't really, it was asymmetrical. And she also complained of burning pain on both legs. Her son also said that she was previously independent to basic daily life activities. And he also tells that she's been having sporadic fever episodes, weight loss. She lost 7 kilos, which is 15 pounds in 4 months, and daily nausea. She had no urinary, respiratory, or other GI complaints, no history of trauma, cervical, or back pain. For her past medical history, it's pretty short, so I'm going to put it on the second aliquot as well. She has hypertension, for which she's using Losartan and hydrochlorothiazide. And she has breast cancer. She did a left mastectomy 12 years ago and had used tamoxifen for 5 years. She's also previously a smoker. She stopped 30 years ago. That's it.
Take it away, my friend, please.
Wow, thank you so much, Eduardo. That's a lot of new information. I will maybe try to talk a little bit about the bilateral ear effusion and failure to the antibiotics, and then kick it off to Robbie. I'm not an HNO. In Austria, it's called HNO. I don't know what it's called in America, specialist. But when I hear bilateral ear effusions, I always prioritize an infection, which could obstruct the flow through the ear, and then the secretions can't pass it, and then there is stasis, and then there is inflammation and bacterial superinfection. And the fact that it didn't get better with antibiotic, we can put our antibiotic failure schema on. Is it the wrong bug? Is it the wrong antibiotic? Isn't it infectious? Is it a different cause, for example, an autoimmune condition, for example, GPA does this notoriously. And yeah, I would go into this direction. And when it's accompanied by the fever, we know fever is the most specific sign of inflammation, so we would prioritize an infection, but an infection for 3 months would be a little bit odd. Could be, that would push me more to the atypical infections, for example, endemic fungi or mycobacterial infections, but also autoimmune, where we're back at the autoimmune bucket, but also malignancies, and which is intriguing with her past medical history. Yeah, Robbie, what do you think?
Oh, that is such an outstanding reflection on chronic otitis media and with a fever. I think that's absolutely superb. You've left me the juicy part, so I'll tackle a part, only a small aspect of it, and then pass the mic to you. Which is the very intriguing part of this is that you now are pretty confident that this is neurologic in nature by virtue of the sensory symptoms. That pushes you much more that there's something neurologic going on. But I now see why the neuro team wanted internal medicine to be involved. And here's the fun fact. Most neurological diseases are non-inflammatory and isolated to the central or peripheral nervous system. It's very rare that you get a hectic inflammatory neurologic disease. And there are many examples, but most people who have neuropathy or myopathy or a stroke or a tumor in the brain don't have prominent systemic inflammation as a feature of it. What is even more unusual is the sequence of events, the sequential loss of function from the left arm. I forgot the pattern because the pattern doesn't necessarily jump out to me. It's just the fact that one body part fell after the other. And that is a pattern that is evocative, though not diagnostic, of mononeuritis multiplex, which again is one of the few ways that an inflammatory disease can actually coexist with a neurologic syndrome. So I think that before you examine this patient, your working hypothesis should probably be mononeuritis multiplex, until the exam moves you that way. And I'll pass the mic to Sammy to share with us what he thinks about that condition, mononeuritis multiplex. But I'll offer one caveat. Remember that sequential neurological diseases have a DDX beyond mononeuritis multiplex, and the onus is to make sure that you're not dealing with something in the cord. A brainstem or anything above the cord seems unlikely because the face is spared. So here I'm either mononeuritis multiplex or that there is an atypical presentation of a cord lesion. And the reason it's atypical is because cord usually equals symmetry. When the cord is involved, there tends to be symmetric disease. And so that's the reason it would be unusual. So I think we're probably going to call this mononeuritis multiplex until the exam. And I'm curious, Sammy, how does that DDX fit with you?
Yeah, that's actually quite an interesting chief complaint. We think we have inflammatory mononeuritis multiplex because, for example, diabetes can also do it very rarely, but this wouldn't be inflammatory. So we would prioritize an inflammatory process. And most notoriously, rheumatologic diseases do it in my experience. So mostly the small vessel vasculitides, but also the medium vessel, for example, polyarteritis nodosa or cryoglobulinemic vasculitis can also do it, I think. But we shouldn't forget infectious causes, especially HIV, syphilis, Lyme disease. and also paraneoplastic causes. I'm sure cancers can do a mononeuritis multiplex, that I don't know. But it's very important to keep all those things in mind when we progress further, I think.
I completely agree. We've already hit esoteria and we haven't gotten the exam yet. So Eduarda, please check us if we're very wrong.
Okay, let's go for the physical examination. She had a BP of 140 by 70. Her heart rate was 77, respiratory rate 18, and her saturation was 98%. She was ill-appearing, pale. She was awake and oriented. Her cardiovascular, pulmonary, and abdominal exams were within normal limits. Her neuro exam, she had an asymmetric loss of muscle strength that was worse in her distal left arm. She had normal deep tendon reflexes. She had hypoesthesia on both legs. She had an ataxic, is it gait? Okay. With a positive
Whatever you
lumbar
want to
side.
call it, honestly. You said it right the first time, gait.
Okay, gait. With positive lumbar sign. She had no signs of meningeal irritation. And she also had normal oropharynx and nasal cavity, and she still had a bilateral ear effusion. There are a lot more data on her exam, so if you want something specific, you can ask.
Let's hear some Sammy magic, please.
All right. Yeah, I think what's obvious is that the effusion is still there, the bilateral ear effusions, but also now this neurologic exam is really interesting because we have signs of sensory ataxia. We have motor and sensory ataxia. Motor ataxia would be, for example, a cerebellar process, and sensory ataxia points us maybe to the spine, but also to the peripheral nerves. So we can focus more on that, which is very interesting. But we also have signs of motor strength. So this definitely points out. So in my opinion, I would prioritize a polyneuropathy, which affects the sensory muscles, sensory nerves, but also the motor nerves. Although a spinal process could still be in play. I will also look for the skin if there are any signs of leukocytoclastic vasculitis or any swollen joints, or if the spine is tender at some point, if we have a spinal level. But those would be my first thoughts. Yeah, Ravi, what do you think?
I completely agree with you. This is poetry, really. And if you summarize, the presence of normal reflexes makes a subacute process unlikely to be in the central nervous system. And so now you're in the peripheral nervous system, and the combination of motor and sensory rules out a myopathy. So you're much more likely either in the plexus or in the nerves. And here, the plexopathy is possible, but having multiple simultaneous plexopathies is very unusual. So you're in the world of probably a polyneuropathy. But this is violating the rule of polyneuropathy. Bland polyneuropathy is always symmetric, sensory predominant, slowly progressive, and all those three S's are broken. This is asymmetric, motor predominant, really, with the amount of weakness this person has. And this is not slowly progressive. This has taken somebody from normal to 2 months. So the three cardinal rules of polyneuropathy are broken, which begets the three other possibilities. That this person has a demyelinating polyneuropathy, which has an interesting DDX, has what's called an aggressive sensory motor axonal neuropathy with things that I already mentioned, or has mononeuritis multiplex. And the pattern here of asymmetry and symmetry is evocative of mononeuritis multiplex, as we were worried about. So I think the next step is to see what the systemic signature of this disease is outside the neurosystem to help us understand what the neural lesion is. And so for that, we'll pass the mic back to Eduarda.
I swear to you, this is not a neuro VMR. So let's go for the exams. So initially, I'm gonna go for the initial exams first. So the white blood count was 22 with predominant neutrophilia, a hemoglobin of 8.6, platelets of 717, sodium, potassium, magnesium, calcium, and glucose were all normal. She had a creatinine of 3.68 with a baseline from 1 month ago of 1.0. Her BUN was 50. Her CRP was 223. Her ESR was 77. And on her urinalysis, we found hematuria with 36,000 erythrocytes per camp. We also asked for a renal ultrasound that was normal. And for the neuro exams, we asked for a MRI of the spine that had no medullary compression, no findings that explained this case. Her CSF was normal. We did a head CT that showed bilateral mastoiditis and diffuse sinusopathy. And we did an electromyography that was compatible with mononeuritis multiplex. That's it for the fourth. And then the next one, we're gonna break it down to the final diagnosis.
Wow, Eduarda, thank you so much. That's really a juicy aliquot with a lot of information. Maybe I will tackle just the CBC and then kick it over to Ravi. So we have a leukocytosis, which seems neutrophilic predominant, which points us to signs of inflammation at first. We could look at the smear if there are blasts or something else. But first I would prioritize inflammation. And then the combination of low hemoglobin and thrombocytosis is also suggestive of chronic inflammation. I learned this pearl one from Ravi and Reza, and we don't have night sweats here, but if she has thrombocytosis and we think of inflammation, it prioritizes more a solid over a liquid cancer. And with the rheumatologic diseases, it more prioritizes an serologic negative rheumatologic disease, for example, polyarteritis nodosa, for example, and where lupus, for example, would more have thrombocytopenia. And yeah, this CBC points me towards chronic inflammation, which fits to our picture. And yeah, for the creatinine and the UA, I would kick it away.
Oh, superb, my friend. The job that you've done for me is to make it easy to help me localize the inflammation. And you have significant kidney involvement, and that is merged with a very unique finding on the UA. The UA shows that there is bleeding, and the question is, well, where is that bleeding happening? And if the UA shows a lot of proteinuria in this context, you've diagnosed to a high degree of certainty the presence of glomerulonephritis. Now, how can you be confident that you're dealing with glomerulonephritis? It should be your working hypothesis until you've proven otherwise, because you have the combination of AKI and hematuria. The only other cause of AKI and hematuria simultaneously is macroscopic hematuria visible to the patient along with urinary obstruction. So when you see such amount of red blood cells in AKI and no report of pelvic congestion or urinary frequency or urinary obstruction, you have to assume it's glomerulonephritis. And that fits with the picture of chronic inflammation. And the good news about glomerulonephritis, it really, really emphasizes the base rate of glomerulonephritis is an ANCA-positive glomerulonephritis. So that is the most common cause, which fits well with her upper airway symptoms. But we have to be careful. There are other immune causes that are not ANCA related, and there are infectious diseases that we have to think about, the most notorious of which is endocarditis. So blood cultures are probably the most important test acutely. But the combination of AKI plus hematuria and the absence of urinary obstruction suggests glomerulonephritis. And I think the final synthesis that we have to do is how the GN would merge with the EMG findings of mononeuritis multiplex, which I'll let you tackle, my friend.
Yeah, when I think about glomerulonephritis in combination with mononeuritis multiplex, I don't know if a whole lot of things can do it. I mostly think of the small vessel vasculitides, especially the ANCA associated. Here in this context, I would most think about GPA, but also polyarteritis nodosa, which usually does not cause glomerulonephritis, but some experts, I think, my nephrology doctor once told me, I think, that some people still think that it's like a friend of MPA, or not a friend, it's like a version of MPA, and because they share similar epidemiology, so it could still be that, I don't know. And yeah, that's mostly where I'm at. Infectious endocarditis is definitely a do not miss diagnosis here. I would also go back to the patient, maybe look at the fingers, look at the hands if you have any signs of peripheral emboli. Yeah, but also HIV can do it for sure. Glomerulonephritis and mononeuritis multiplex. I usually do not associate syphilis with GN, but it can cause, I think, membranous glomerulonephritis, which would cause more of a nephrotic syndrome in my to my knowledge, but I'm not really sure about that. What do you think, Ravi?
Absolutely superb. For those of you tuning in, you're like, what language are they speaking? You know, we started this case with like, oh, there's progressive weakness and everything is ending with some fancy word. And this is how hard this case is. There's so many complicated and rare things going on. Glomerulonephritis, exceedingly rare. Mononeuritis multiplex, even rarer. So this is the depth of esoteria. But I think Sammy is reminding us that you have to remain humble and make sure that you're not being fooled by something more common like HIV, like Lyme, like leprosy, like what was I going to do the last one? There's another big, the other biggest mimicker is endocarditis here. But I think the exercise, if you're trying to be as precise as you can be, is that you have a glomerulonephritis with mononeuritis multiplex and you have upper airway symptoms. That is most suggestive of an ANCA-associated vasculitis. And for me, it's a toss-up between GPA and MPA. I can't quite figure out which one it will be. Frankly, it doesn't really matter too much. Because MPA is microscopic polyangiitis is much more likely to cause mononeuritis multiplex. But GPA is more likely to cause upper airway symptoms. Now, both of them have enough overlap that it could go either way. Before you are progressing towards diagnosing ANCA-associated vasculitis, you should think about the infections it can mimic, but you should also take a pit stop and make sure that it's not a drug-induced ANCA-induced vasculitis. So if we look at the med list and actually learn that the patient is on hydralazine and not losartan or hydrochlorothiazide for her blood pressure, that would be important. The other important thing is to make sure there isn't exposure to levamisole, which is classically is an adulterant in cocaine, but can occur in other places. That's another big mimic to think about. But I think, you know, in this case, I agree with you, Sammy. I think we're most worried about an ANCA vasculitis, and we'll see what Eduarda has in store for us.
Okay, let's go. So her cultures were negative. We researched hepatitis B, hepatitis C, HIV, and syphilis. They were all negative. We also did a cryoglobulins testing. They were also negative. She had no complement consumption. Her ANA was negative, and she had a chest CT with small pulmonary nodules. During her hospital stay, everything was happening all at once. So during her hospital stay, her renal function progressively worsened. Her creatinine went up to 4.55. So we decided to perform a renal biopsy. And the renal biopsy evidentiated diffuse proliferative glomerulonephritis with signs of sclerosis and fibrocellular crescents. So, and the immunofluorescence came back negative. So it was a rapidly progressive pulse-immune glomerulonephritis. We ended up starting her on post-steroid therapy and cyclophosphamide, and she slowly started to improve. We also did her serum markers for ANCA-associated vasculitis. And while she was already treating, the exams when they were done, they were ready, and she had a p-ANCA positive, an anti-myeloperoxidase positive, and her anti-proteinase 3 was negative. And so the rheumatology service in our hospital ended up, until this moment, putting a final diagnosis of GPA. But it was very interesting because the serial markers were more associated with MPA, but it's not impossible for the GPA to also be associated with PNCA or anti-myeloperoxidase. So for the upper airway part of her case and the pulmonary nodules, it's GPA, but at the end, it really doesn't matter. Just like you said, the treatment, it's the same. And there's also, I was studying, and there's also this current in the literature that wants to call it a PNCA associated vasculitis and not like GPA or MPA and such. So it was very interesting. And I just wanted to just make a very short comment that when we received this patient in the ER, we were so focused on her neuro symptoms, so much on the weakness, and the sinusopathy and the ear effusion was kind of cast aside. And I remember when she was transferred to the wards, and I was also the resident in charge of her case in the wards. And it was so hard to put the sinusopathy in the same bag as the mononeuritis multiplex and the glomerulonephritis. And when I actually presented the case to my professor, he was like, oh, this is an ANCA-associated vasculitis. It's very clear. So it's very interesting how a history taking properly done can change so much when you think about the diagnosis. So I just remember when I talked to her son in the wards, and he said to me, it all started with the hearing loss. That's when it started. So we could think that the sinusopathy was a red herring, but it's actually a very important part of the case. So it was a great case to learn from.
Oh, your humility knows no bounds. That was such a great reflection. Thank you. Sammy, what are your thoughts?
Yeah, thank you so much, Eduardo. That was just an amazing case. I learned so much, and as I can only agree with Rabi. And it's just so hard to distinguish between noise and what's really important for this case, because you can also say this sinusopathy and the mastoiditis are not related to this presentation, but that's why it's so important, I think, to always have two schemas, one with these symptoms and one without it, and go down both pathways. And that's like, we never stop learning, and I learned so much today. And also the discussion with Rabi was just so awesome. Thank you so much for this opportunity.
Oh, this is such a special treat, to have Eduarda presenting from Brazil as just beginning her training is just absolutely incredible, and to have that be peppered with the authentic experience of taking care of, like, all of you are probably in a situation where GPA could just show up at your doorstep unput together yet, and your job is to put it together. And I think we could tell. It was very easy to tell how much you had thought about this case, Eduarda, and how you told the story very deliberately and carefully to make it easier for us. But in real time, you never know what's relevant and what's not, right? But you've made a very deliberate effort to only present the things that are relevant. Otherwise, it's not a case presentation. I guarantee you, if you look at her chart, stuff that you haven't included here is noise. And in doing that in real life is very, very hard. Discussing it on VMR, you've already done the work for us. And so I really, really appreciate that. And I think these are the kinds of spaces where you can practice, and then real life, it's a much harder distinction. The chat is going crazy with trying to label this diagnosis. And two of my favorite comments were from Travis and Nikita with GPA with an identity crisis, and Hans actually GPA with the wrong INCA. And let me take a minute to try to give it my best shot to explain. So what is the fundamental difference between GPA and MPA? It actually goes back down to the name. So MPA is microscopic polyangiitis. It is just a small polyimmune small vessel vasculitis. What's really special about GPA and EGPA is the word granuloma. It is one of the few times that a granulomatous disease overlaps with a vasculitis. Very rare and very unique. Now, what is that core distinction? MPA has no extravascular features, with some exceptions. Most patients with MPA present with a pure vasculitis syndrome. So here is the extent of the upper airway involvement, and most importantly, the nodules. Those are extravascular manifestations. So the more extravascular manifestations, i.e. disease manifestations outside the vessel, the less likely MPA is. But there are exceptions to that. MPA can cause a bronchiectasis. It can cause usual interstitial pneumonia. It can do something. So we only allow some exceptions. But lung nodules, we don't allow that for MPA. It's too much of an exception. And so I think that's where the GPA becomes stronger. And then how do you marry that with the fact about the serology? About 10% of GPA marries with the wrong ANCA. Usually it's along with C ANCA with PR3, but in 10% of cases, it's a P ANCA along with MPO. So I think here, the lung nodules for me are the biggest distinguisher, and allows you to accept the fact that this happens 10% of the time with GPA, that it buddies up with the wrong ANCA. But what do you need to know? None of this. This is all esoteria. I think what you need to know is a patient with an inflammatory peripheral neurologic syndrome has a high risk of vasculitis. I think that's it. You see like weird neuro and inflammation. The most important lab to check is the creatinine, because most of these patients will have glomerular involvement. So I think that's the biggest takeaway practically. And then if you want to get fancy, know that the biggest difference between MPA and GPA is the G, and the G means extravascular stuff. All right. Oh, I rambled so much. I couldn't help it, Sammy. I couldn't. All right, Shema, take us home, please.
So thank you so much, Eduardo, for the case, and Sammy was just brilliant as always. And yes, I am starting with the teaching points and trying to keep it short because we're over the time. So we had progressive weakness as a chief complaint, and the key question is it asthenia or is it true weakness, or so any neurological thing? And the key question is just ask, are we weak when they're lying down or only if they activate the muscle? So it's a great question to differentiate between these both. And then we were also talking about the mimics of neurological issues. So is there any limb ischemia or some pseudoneurological issues like orthopedic stuff? And if we have bilateral ear effusion, what we learn is we can think of an infection, something like a chronic otitis media, or autoimmune processes like GPA, relapsing polychondritis, or malignancy. And talking about antibiotic failure, so consider, is it the wrong bug? Is it the wrong antibiotic? Or is it something non-infectious? Or do we have something like a problem with tissue penetration? And then we're talking about mononeuritis multiplex. It's something where we have the combination of an inflammatory process together with a neurological problem. And we could think of diabetes rarely, and then otherwise we should prioritize a rheumatologic disease, something like a small vessel vasculitis, cryoglobulinemia, medium vessel vasculitis like PAN, or HIV, Lyme, Hep C, syphilis. And then what we also learn is like if we have a spinal cord lesion, we should think of symmetric lesions. And then the combination of low hemoglobin and thrombocytosis should let us think of a chronic inflammation. And then we also learned if we have a glomerulonephritis with mononeuritis multiplex, think of small vessel vasculitides. Also of panarteritis nodosa, what we learned from Sammy is it's kind of a version of MPA, and also think of common things like infective endocarditis, also HIV, syphilis, and then trying to differentiate between MPA and GPA. MPA is much more common to cause mononeuritis multiplex and usually doesn't cause any extravascular features. As we know, it doesn't make any granulomas. And then talking about GPA, usually we have upper airway involvement and also the extravascular features. And we're also talking about the drug-induced vasculitides like think of hydralazine. And then talking about AKI and hematuria and the absence of obstruction, always think of a glomerulonephritis. And yeah, so I would stop here. Thank you so much. and hope to see you again soon. Thank you so much.
Superb, my friend. Superb. That was a lot of learning. Packed in 30 minutes. Thanks to Eduardo and Sammy. Appreciate you all and see you tomorrow. Bye now.
Bye.